Hello and welcome to the DESERA Clinical Education Oncology Podcast. I'm your host, Ryan Topping. Today's episode features Dr. Jesus Berdeja from Tennessee Oncology in Nashville, Tennessee, Dr. Amrita Krishnan from City of Hope in Irvine, California, and Dr. Niels van de Donk from Amsterdam VUmc in Amsterdam, Netherlands, as they address key questions on CELMoD agent therapy for multiple myeloma, including combination strategies, adverse event management, and where CELMoD agents may best fit within current and future treatment strategies. This episode is part of a larger educational program titled Myeloma Mythbusters, investigating the now, soon, and future clinical implications of CELMoD agents. For more information, along with a link to the larger education program, please visit the show notes for this episode. Now, let's get started and hear what our experts have to say about this important topic.
Could CELMoD agents enhance immune activation in combination with CAR T-cell therapy or bispecifics? I know that both of you are involved in an interesting clinical trial. You with MESI and you with IBR, I think, after CAR T. So maybe, Amrita, you can comment on this?
So the data you so nicely showed in terms of its effects on T cells clearly suggests it has a role both with bispecifics and as well in the post-CAR T setting. I think we also already have data of combining bispecifics with immunomodulatory agents that we're also going to see further at this meeting. So this is sort of the next generation of those trials.
I agree. I don't think it's a debate. The question for me is, when do we incorporate them? So do we treat with them before you collect the T cells to get a fitter T cell as part of your CAR T? Do you bring it on as maintenance after the CAR T, hoping to kind of continue that activation and maybe suppressing and leading to longer durations of responses without activating or increasing toxicity? Because ultimately that's the problem, right? So at some point we may do too well, and do you really want those T cells to live forever and then have these long-term toxicities? So those are the questions that come up. That, sometimes a little can be too much. From all our experience or little experience that we have in trials, these seem to be really good agents to combine with CAR Ts and with bispecifics as well.
So I was going to ask you a question then, Niels, but would you give, to your point about when you do it, would you give a bispecific combination and then would you stop one of them and continue a CELMoD agent, for example?
Yeah, I think that's a very important question because now the bispecifics are given until progression. And the big issue is, of course, with the BCMA bispecifics, is that you continue to have zero B cells, zero normal plasma cells, no humoral immunity. So I think now that bispecifics are coming to the early relapse setting, are coming to the newly diagnosed setting, I think we have to think about fixed duration so that patients can experience B cell reconstitution, normal plasma cell reconstitution, so that you can stop IVIG, and it can take sometimes several months before humoral immunity is recovered. So I think it would be very interesting to explore fixed duration bispecific, maybe followed by a certain duration of a CELMoD agent to maintain the remission. Maybe it is not needed, so it would be interesting to explore both fixed duration and CELMoD as a maintenance strategy. Yeah. Because we know that we induce a very high rate of MRD negativity, especially when you start combining bispecifics with other drugs.
I mean, the other thing again, we all have very limited experience incorporating these agents, but especially in the post-CAR T space is, as you'll see, the main toxicity of these agents by definition is neutropenia. And so sort of trying to navigate that immunosuppression that can result from the agents, having to stop, how much do you need? And I don't think you need that much. I think you can do a very short amount of treatment and actually stop, and it actually does induce prolonged responses. So.
Okay,
maybe
so then
one question for my clinic. Last week, 2 weeks ago, I had a patient that got a CAR T-cell product. He had massive expansion. And in this trial, we had to start with lenalidomide maintenance at day 28, but he had a lymphocyte count of 50. So I didn't do it. I wanted to wait until the whole peak was a little bit down, because during the expansion, he had also transaminitis, high LDH. So I wanted to wait a little bit with the immune activation by an IMiD. So when do you think is the best moment to start CELMoD or IMiD maintenance after CAR T? What is your practice, or is your trial saying?
Yeah, no, that's a good question. I agree. I would not start it then either, because not because we know what will happen, but just because of the potential of inducing, again, these sort of later toxicities. But I think in general, it's when you get hematopoietic reconstitution. That's usually when, again, because of the toxicity or the potential side effects of these drugs, that's usually the window where so it's usually about 30 to 60 days after the CAR T in general.
Yeah, and I think you should also wait until all the toxicities, the lab toxicities, the neurological toxicities.
Yeah, maybe not while they're having CRS or neurotoxicity.
So here's my question, because you mentioned you have the IBER post-CAR, we have MESI. Do you think there's one is better than the other post-CAR?
Yes.
Oh.
I don't know.
Niels, you want
Good
to
question to me.
You could be the
You are the
tiebreaker.
expert. You do MESI and you do IBER.
I don't know which one's better. I can tell you that I think I would use, because again, in this setting, we're not using them for their anti-tumor effect, right? We're using for the immune modulating effects. And I think the better toxicity profile is with IBER over MESI. So I personally would think IBER makes most sense.
I think I would also favor IBER, although I don't have clinical experience in the post-CAR T setting with IBER. But given the lower rate of neutropenia, I think IBER is a very good maintenance drug, also in the post-CAR T setting. I only have experience with LEN maintenance after CAR T at this moment.
I'm actually going to pick one of the other questions to ask them because I think it's important. So we see a lot of neutropenia with this agent. So I'm curious how you guys manage the neutropenia. You have a patient in front of you and you're expecting to get neutropenia. So what do you do as Dr. Krishnan? You're shaking your head, so I'm going to ask you first.
Well, I see our research nurse actually sitting in the back who we have a patient on trial with MESI right now, and that is very much a significant issue. Fairly profound neutropenia, and this is fairly advanced relapse disease post-CAR T, and so it's that challenge of we don't really want to have to hold drug for long periods of time. We've been basically now giving just scheduled growth factor to try and maintain dose.
We also give growth factors, and at a certain time point, of course, also dose reductions, both to keep the patient on treatment, therapy, because we think that that will result in a longer duration of the response. So both growth factor support, pendulated GCSF, I think is easier than GCSF, or dose reductions after a while.
So
I
I'm
think
curious.
the one good thing, though, is that the thrombocytopenia does not seem as prominent. So as Niels said, the neutropenia is manageable.
So I'm curious, you have a patient in cycle 1 and become neutropenic. Do you do immediate dose reductions, or do you try GCSF and see if you can maintain the dose intensity?
First, I try GCSF.
Yeah.
If you continue to need GCSF while tumor burden has substantially decreased, the patient's in a deep remission, I tend to go down in the dose.
Yeah, I take that same approach, too.
Yeah, but I think that's important because obviously we're taught and we're told by insurances that you shouldn't give your growth factor while you're giving chemo. And so I think we need to kind of dissociate that from these agents, that it is safe to give growth factors during and really to try and maintain the patient on there, especially initially when they may have disease in the marrow that is complicating this further. So I agree with you, but I think it's hard. I think it's ingrained in us, right? That it's like, oh my God, they're neutropenic, we need to stop. So, but yes, I agree.
And the important thing maybe, neutropenic fever is very rare with the CELMoDs. Yeah. Also with mezigdomide, that's a rare type of infection.
I think the other thing, and maybe you'll talk about this in your maintenance study, because I was happy to see that the quality of life was included in terms of much less diarrhea.
Yeah. That's one of the assets that you also mentioned, that with IBER, but also with MESI, other than infections, grade 3 or higher adverse events are very uncommon. So I enrolled many patients in the maintenance study, EMN 26, European Myeloma Network study 26. And none of my patients on IBER needed for diarrhea management, cholestyramine or Questran or Cholestigel, drugs that you typically have to give to patients that receive lenalidomide maintenance. So in terms of quality of life, diarrhea, there is really a difference. Fatigue, incidence of neuropathy, very different side effect profile.
Yeah, that's a great point. I'm just going to go back that we're not saying that if a patient has neutropenia and a fever or an infection that you should continue therapy. But if it's truly just neutropenia, then again, I think it's worthwhile to use the growth factors and not immediately kind of hold or dose reduction. Now, would you feel the same way if a patient is doing well on treatment and in cycle 6 they become neutropenic?
Yeah, I think then I agree with Niels too, because then you sort of, depends also how many dose reductions you've done, right? And that's where you're going to weigh that. If it's you haven't dose reduced at all, then sure, I'm going to dose reduce and maybe see if I can get away with a little less growth factor then. And
you agree? Yeah, so I agree. I think, again, at the initial first 2 cycles where we may have tumor burden, I think you're more tolerant of neutropenia and really pushing and doing growth factors. But if the patient's now in remission and now they're still becoming neutropenic at that point, you definitely probably should dose adjust. Anything else? Any final thoughts on?
I guess I have a question too. Do you think a PI is a better partner or a CD38 antibody for a CELMoD agent?
When you look at the mode of action, you would never have tried to combine CELMoDs with proteasome inhibitors, right? Because you need the degradation of Aiolos, Icaros by the proteasome. So you would argue that the combination with the proteasome inhibitor is a very bad one. But in the clinic, luckily enough, before we knew about the existence of cereblon, we tested this combination. And Len with Velcade was very effective. And I think also Iber with Velcade dexamethasone in transplant ineligible patients is very effective. But also from the immune perspective, the combination with CD38 antibody looks very promising. I have some patients from the CC220 MMO1 study that are still on Iber and CD38 antibody since many, many years with a very good quality of life. So I think it's also, well, very good combination, which we will learn more from when the data from Excalibur relapse refractory study will read out. Maybe I can ask one question, that is, should we test T-cell exhaustion prior to starting a bispecific antibody in all the patients, and can help us that in the future to make a better choice when it comes to combination strategy?
Should we do it? I think it would be nice to do it, but it would be nice to have a specific definition, right, of what's likely to work and what's not likely. I think we all kind of know, but it doesn't always pan out on everybody, and it's also, I think, difficult to do in real time, I would think, to do that. At least in the community, it would be very difficult to kind of get that information. So we have to send it to Dr. Krishnan, Dr. Donk in their labs to kind of do it for us, and then kind of wait for UPS. And that's not ubiquination, that's actually
And then 6 months later,
results.
after we batch all the samples.
But ideally, yes. I mean, I think if we could identify the patient that is likely to respond versus not respond to a therapy, we definitely should do that, and especially with these T-cell redirecting therapies.
Yeah, I think it would be nice to see which patients are doing very well with monotherapy, because some patients with teclistamab or elranatamab or linfoseltamab as monotherapy achieve CR that's very durable, and they don't need a partner drug, which can also induce extra toxicity, and which patients are really doing better with daratumumab, with an CELMoD. So in the future, hopefully this type of translational studies will give us more information. So where do Iber and Mezi fit in? Well, both agents have activity in IMiD-exposed and IMiD-resistant patients, as shown by Jesus, but the profiles of adverse events and relative opportunities are different. So let's see how Mezi and Iber differ from each other and what are their similarities. So both Mezi and Iber are orally administered agents. They are effective in heavily pretreated patients, including those refractory to lenalidomide and pomalidomide, and they are all studied in early lines of treatment and in combination with other anti-myeloma drugs. The type of clinical trials where these agents are being evaluated is different. They have a different design, different partner drugs. Another difference is that mezigdomide has greater cereblon binding potency and greater subsequent downstream anti-myeloma effects. However, this is at the cost of a higher rate of neutropenia, because iberdomide is probably more tolerable, especially when you give it as a long-term exposure, because of the lower rate of severe neutropenia. So these agents probably have a different role in the future treatment landscape of myeloma. Iberdomide is probably a good option as a post-transplant maintenance therapy. When you think about maintenance, you want to give it for a prolonged period of time, and this is probably very well possible with iberdomide because of fewer non-hematologic adverse events versus IMiDs and a lower rate of neutropenia compared to the CELMoDs, compared to mezigdomide. On the other hand, mezigdomide has probably an important role in patients with poor prognosis, such as patients with high-risk cytogenetics and in patients with extramedullary disease. And of course, in combination with other drugs, mezigdomide has also a potential role as a relapse therapy in earlier lines of treatment. In a perfect world, Amrita, where would you see the roles of the new CELMoD agent category?
I think in the maintenance setting, certainly replacing lenalidomide for the reasons you mentioned in terms of toxicity. And in the post-BCMA therapy relapse setting, I would say there is a big space there for them as well.
So I have to say, I think some people want me to say that at all stages of myeloma, we should be using them. But I actually have been intrigued by the patients who have progressed on BCMA and GPRC5D directed therapies immediately after those agents, and then putting them on one of these agents and actually seeing some very impressive results. And so I think that is an unmet need, and I think that's actually a place where I would love to see him like now, if I had my hands on.
Absolutely. Yeah. I also have that experience because when patients are BCMA, GPRC5D exposed, that's the true unmet need today. And I also saw very good results with iberdomide, and you showed some interesting results of mezigdomide in that setting. Maybe they improve again T-cell function and thereby inducing these sometimes very durable responses post-bispecific or post-CAR-T.
Thank you, Dr. Berdeja, Dr. Krishnan, and Dr. Donk, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Myeloma Mythbusters, investigating the now, soon, and future clinical implications of CELMoD agents, please click the link in the show notes. And be sure to check back regularly for more episodes on important DSERA clinical education oncology podcast topics.